Okay, so good evening everyone. Good day, good evening, good morning. Kung kano sa mong tanaw ni, good afternoon, no? Today we're gonna be discussing the last topic of our semifinal coverage. This is our drugs affecting the endocrine system, or episode 8, no? Now, class, no? Listen to me, ha? Typically, these types of drugs will address, okay? It will address either endocrine disorders, okay? Or they are used for specific indications, okay? Specific indications. Now, a brief overview of your endocrine glands, no, or endocrine. Your endocrine glands, no, or your endocrine system is made up of glands. Okay, these glands regulate functions of the body using what we call our hormones. Okay, typically these hormones will have a target organ, an organ where their function will their function will be apparent, no? Apparent. So these hormones will go to their target organ. And this target organ, no, will elicit that function. Okay? Function or effect. Ayan. Now, typically speaking, when we are talking about endocrine disorders, no, there are two types. Okay, there are two types. I want you to listen, ha? The first is hyposecretion. When we say hyposecretion, class, it refers to a decrease in the secretion of hormones. Okay, a decrease in the secretion of hormones. Okay, there is also what we call hypersecretion. When we say hypersecretion, it is when the endocrine glands will overproduce hormones. So there is an increased amount of hormones. Yan na siya, increase or decrease. Typically, since they are increase or decrease, no, their effects are the opposite. No? For example, class, when I say something like hypoparathyroidism, it will refer to a decrease in PTH or a decrease in parathyroid hormone, also known as your parathormone. This is a hyposecretion from the word itself, hyposecretion. Whereas when we say something like hyperparathyroidism, then that is when the parathyroid gland will overproduce daghan kay sa gimuon nga parathyroid hormone or PTH, no? So ingana na siya, class. Now, when it comes to treatment, typically hyposecretion, when there is a deficit or a decrease in hormones, what we usually do is we will replace hormones. So we will give them replacement drugs, no? Hormones, the replacement of hormones. Or we could also stimulate gland production. So that is how our drugs work. Okay? If the patient has hyposecretion, let's say hypoparathyroidism, then we will either replace the parathyroid hormone, or we can tell the parathyroid gland to increase its production of the hormone. Okay? Whereas, class, when it comes to hypersecretion, then our treatment will usually revolve around either inhibition of hormone release. Okay? When we say inhibition of hormone release, we are trying to stop the production of parathyroid hormone or the production of hormones because there's too much, di ba? Hypersecretion, no? Or we can remove the gland. Okay? For example, guys, in this instance, no, hyperparathyroidism, the surgeon could say something. The surgeon could operate on something like a parathyroidectomy. This is when we remove the parathyroid itself. If you remove the parathyroid, then wala na yung production sa parathormone. So, it will decrease the parathormone or parathyroid hormone. Okay? Now, a short disclaimer lang before we start, no? This is quite a very, very difficult topic. Okay? It just so happens to be to be honest with you, it just so happens to be my favorite. No? Out of all the systems class, akong pinaka-paborito ang endocrine class. Nga naman, because if you really understand the hormones, it's very, very easy. If you memorize, if you understand the function of every hormone, it's very, very easy. But if you don't understand, then it will feel like neuro. Lisod gyud siya if it's very, very hard if you don't understand. So before I'm gonna discuss, no, I'm gonna show you, okay, an anatomical overview and then a short pathophysiology. However, we will not focus on on the diseases specifically today, no, because that's for MS. Dili ta mo delve deeper into the diseases. I will just give you what happens when the disease occurs and how the drug, no, affects these diseases. Okay? So these are our discussion topics. We have our pituitary agents, thyroid and parathyroid agents, and adrenocortical agents. Our anti-diabetic agents class, I will leave them for part 2 because anti-diabetic agents are one chapter on their own. Ilahar nga chapter class is actually very long. And I'm telling you, anti-diabetic agents are very, very important class. This is the most common question in the board exam. Mga anti-diabetic agents, insulin, kana mga let's say for what else, kana mga metformin, no? The reason why anti-diabetic agents are very common is because, I don't know if you know this, the Philippines is the diabetes capital of the world, no? That is mostly due to our overconsumption of rice, no? And that's quite concerning, no? Sige, so let's continue. Let's start with our pituitary drugs. Okay? Our pituitary agents. Now, in order for us to understand our pituitary agents, let's talk about the pituitary glands. First, there are two. The anterior and the posterior. Now, the pituitary glands, no, they are controlled by our hypothalamus. Okay? The hypothalamus. Now, many people, some books will say that the hypothalamus is the master gland. No. The hypothalamus is just the gland that will releasing or inhibiting hormones. Okay? Now, it might sound difficult, but listen to me, listen to me. Okay? The hypothalamus class is the controller. While it will control, no, the gland, which is our pituitary, and there are two, anterior and posterior, the front and the back, no? Okay, now listen to me, ha. I will give you an example of how the hypothalamus works, okay? If the hypothalamus releases, let's say for example, class, LHRH. LHRH means it is a luteinizing hormone releasing hormone. Okay? Libog no? Luteinizing hormone, releasing hormone. Now, if that LHRH goes to your anterior pituitary, then the anterior pituitary will increase its production of your luteinizing hormone. It will increase the production nga naman, releasing hormone maning LHRH. Okay? Ano na siya, class? Okay? Now, if for example, there is too much LH in the body. Okay, let's say for example, there is too much LH in the body. So what happens, class, is this. The hypothalamus will detect that. Makakita ang hypothalamus, anak, class, and then they will say, uy, daghan na kaayog LHRH o daghan na kaayog luteinizing hormone. So instead, it will now send LHIH or luteinizing hormone inhibiting hormone. Okay? This LHIH, no, will go to your anterior pituitary, and then it will tell your anterior pituitary to stop producing LH. And because of that, class, this will decrease the LH. This will decrease the luteinizing hormone. Okay? This is the main mechanism when it comes to the feedback mechanisms in our endocrine system, because the endocrine system works on positive and negative feedback. Okay? When I say positive feedback, if there is something that is too much, no, the controller will decrease its production so that it will decrease the hormone that is too much. Okay? When I say something like negative feedback, no? Negative feedback is if, for example, there is a decrease in prolactin, okay? The controller, which is the hypothalamus, will see that, and then it will release prolactin. Asa mo to? Prolactin releasing hormone, PRH, no? Prolactin releasing hormone, and thus, no, it will tell your anterior pituitary, no? It will tell your anterior pituitary to increase the prolactin, okay? To increase the prolactin. So that is a positive and negative feedback. Nga na siya. Now let's talk about the specific hormones, no? Our anterior pituitary class has 7 hormones, no? Our growth hormone, our thyroid stimulating, prolactin, adrenocorticotropic hormone, luteinizing hormone, and follicle stimulating hormone, and melanocyte stimulating hormone. Now, as I've mentioned before, these hormones have target organs, okay? And then when they go to their target organs, they will elicit their effect. For example, growth hormones typically go to your body tissues. They will promote growth, no? The thyroid stimulating hormone will go to your thyroid gland and promote the release of thyroid hormones like your T3, T4, and calcitonin. Okay? Your prolactin will go to your mammary glands and stimulate the production of milk, breast milk, no? Adrenocorticotropic hormones will go to your adrenal glands, okay? And will stimulate the production of adrenal hormones. Adrenal hormones, class, your glucocorticoids, and your mineralocorticoids. Ayan, okay? The LH and FSH will go to your gonads. Okay? The LH will stimulate androgen production, while the FSH stimulates gamete production in your gonads. Now, I'm sure you're very familiar with the LH and FSH, no, from your maternal and child nursing. And then your melanocyte stimulating hormone will go to your melanocyte in your skin and produce melanin. Melanin is the hormone that the enzyme that hormone that produces, what we call skin pigmentation, no? So the more melanin, the darker you are, no? That is for your adenohypophysis or your anterior pituitary. Okay? Now, if maglibog mo ka, sir, I cannot memorize all of these drugs, class. No, I'm telling you, make it simpler for yourself, class. Anterior pituitary, class. Remember, class, GT-PAL. GT-PAL. Oh, murag sa maternal ba, GT-PAL. Isa mo, for our anterior pituitary is GT-PAL, no? Growth, G. Thyroid, T. Prolactin, P. Adrenocorticotropic, A. Luteinizing hormone and FSH, L. And M. Melanocyte stimulating hormone. Oh, GT-PAL. That is for your anterior pituitary. Okay? Huwag niyong kalimutan yan. Okay? And don't forget about its effect or its function and their target organs, no? So, this is a very simplified shari ko kakuha na class, no? We also have our posterior pituitary. The posterior pituitary has 2 hormones. It is our oxytocin. The oxytocin has 2 target organs, the uterus and the mammary glands, no? In the uterus, it will stimulate uterine contractions during labor. And in the mammary glands, this stimulates the release of milk. Milk release after labor, no? I bet you didn't know that, no? Prolactin will stimulate the production, while oxytocin will stimulate the release of milk after labor. Our posterior pituitary or neurohypophysis also produces antidiuretic hormone, which will go to your kidneys and stimulate water reabsorption in the kidneys. Keep that in mind. Water reabsorption, meaning to say water is retained. Okay, it will retain water. Now, it is from the name itself, it's very self-explanatory. Anti-diuretic hormone, meaning to say it will prevent urination. Ayan. Keep those in mind, no? Keep those in mind. If you have time, no? If you want time, please pause the video, no? And read through this this chart that I have made, no? Now, saan man na to pag how do we remember, class, the anterior and the posterior hormones? As I mentioned before, when I say anterior pituitary, just remember GT palm. Okay, GT palm. Okay, how for posterior pituitary, class, just remember APO. APO Hiking Society. Ngano man? Ngano APO man? Okay? ADH and oxytocin released by the posterior. Okay? ADH and oxytocin released by the posterior. Or PAW, or sa pay gusto nimo, or OPA, no? I just like APO. Okay? So, let's start with our growth hormone deficiency drugs. These are drugs wherein they will synthetically replace growth hormone, no? Naamon ko yung mga kuan, class, this is indicated for pituitary GH deficiency or dwarfism. Dwarfism, class, is when there is a decrease in growth hormone. So, we will give them a synthetic. When we say synthetic, it is man-made. Okay, it is man-made. It is a man-made replacement, no? We will give them a man-made replacement of growth hormone. In this instance, no, it is somatropin. Somatropin or genotropin, brand name niya. This is administered via SQ or IM. Okay? Never PO. Ngano never PO man? Because this is destroyed. Okay? Because destroyed by gastric acid. Destroyed by gastric acid, no? So we don't give it PO. Okay. So, what do we need to consider for drugs for GH deficiency drugs? No, what do we need to consider? This must be given or must be administered only before 21 years of age. Now, ingani na siya, class, ha? The problem with dwarfism, no, is there is a decrease in growth hormone. Because of that decrease in growth hormone, the patients typically are very short. Mubo sila, class, short in height. Okay? And no, maybe we don't want that, no? Now remember, these drugs are very expensive. Somatropin is very expensive, you know. So, what do we do? What do we do in this instance? No, we are only gonna administer them before the age of 21. Nga naman. Now, GH, class, will act on what we call our epiphyseal plates. Epiphyseal plates. Now, the epiphyseal plates, class, no, they are found in your long bone. Let's say this is your long bone. Let's say this is your humerus, no? Your epiphyseal plates, class, are found at this portion of the long bone. Okay, at this portion, not near the neck or at the start of the neck of the long bone, no? And what they do, no? What the growth hormone does in the epiphyseal plates is they will stretch out that epiphyseal plates. They will stretch out that epiphyseal plate, no? They will stretch out that epiphyseal plate. Now, because the epiphyseal plates are stretched out by the growth hormones, in turn, the long bone becomes longer, and in turn, your height will increase. Your height will increase. Okay? However, the reason why up to 21 years of age is because epiphyseal plates close at 21 years. Epiphyseal plates close at 21 years. So, typically speaking, pag abot ni mo 21 years old class, that is already your final height. You are no longer able to grow because mauna na siya class, no? Your epiphyseal plates have already closed and you are no longer growing vertically, no? So if this is the person class before 21 years old, they are still able to grow vertically. Okay, but if you give a patient, listen to me ha, if you give a patient who is over 21 years old, they can less than 21. If they are greater than 21 years old, if you are giving them growth hormones class, they are no longer able to grow vertically. Instead, they will grow horizontally. No? We call this condition class acromegaly. Okay? Acromegaly is if there is too much growth hormone after 21 years of age. Wherein, ang imong growth palapad na. Okay? That is not a joke. That is the truth. No? If there is too much growth hormone food before 21 years old, then we call that gigantism. Wherein, ang imong height is very, very tall. Muna siya mga NBA player. No? It is administered starting from the time of diagnosis. Usually, the time of diagnosis is before 6 years old, no? Before 6 years of age, okay? And this will also antagonize insulin secretion. So, this may cause diabetes. May cause diabetes mellitus, okay? Diabetes mellitus, okay? This is contraindicated for athletes, patients who are obese, patients with severe respiratory impairment. Lagyan mo yan ng malaking star class, okay? Lagyan mo yan ng malaking star. And the main reason why is patients who are athletes, who are obese, or patients with severe respiratory impairment might not be able to, listen to me, might not be able to normally develop, no, because ang way manggod, the way athletes and people who are severely obese or people with severe respiratory impairment, the way they grow manggod is oftentimes either too fast or too slow, no? So if you give them GH manggod, it just kind of messes the growth hormone, no? This we need to emphasize the need for regular follow-up appointments with an endocrinologist, especially during puberty. The reason why is because growth and development increases substantially in puberty. So there may be a need to change or alter the dose. Okay, there may be a need to change or alter the dose, and then you need to watch out for fluid retention and changes. No, it is actually quite common class, fluid retention and changes. That is a side effect of the drug, and changes in spinal curvature. No, this is because of the rapid growth. This is due to rapid growth. Okay, so you need to watch out for either kyphosis, lordosis, or scoliosis. Ayan. Yan na. So, muna siya, no? You need to watch out for changes in spinal curvature. Okay? How about drugs for excess growth hormones, no? So, these drugs, no, they will inhibit the release of growth hormones, and they are given for patients with gigantism and acromegaly. As I mentioned before, gigantism is an increase in GH, no, increased GH prior to 21 years old. Okay, whereas acromegaly is the increase in GH after 21 years, no? So, typically, ang iyang characteristic ni class is vertical growth. Vertical growth. For acromegaly, it's horizontal growth. No, horizontal growth. Mulapad ka class, no? Your muscles and bones become wider. Okay? There are 3 drugs class. We have our octreotide, sandostatin, our bromocriptine mesylate, and our lanreotide acetate or somatulin depot. No, these are drugs that inhibit the release of growth hormone. They will stop the release of growth hormone. Okay, So what do we need to do? What do we need to consider when it comes to giving these drugs? Now, we need to monitor the patient's blood glucose closely. Okay, because these drugs can alter, okay, they can alter glucose metabolism. Okay, they can alter glucose metabolism, no? And the bad part about this, no, is they can cause both hyperglycemia. Hyperglycemia is too much blood glucose, and they can also cause hypoglycemia. Okay? And they will rapidly shift, no? Rapid shifting. So one day, basin, if you are taking this drug, you might be hypoglycemic, and then the next day, hyperglycemic na naman, di ba? You need to monitor the vital signs, especially heart rate and blood pressure, because these drugs can cause, no, hypertension, and bradycardia. Okay, that's just one of the side effects of these drugs, no? Rotate injection sites if given subcutaneously or via IM to decrease the risk for lipodystrophy or lipoatrophy. Okay? Lipodystrophy, gani class, is the destruction of fat surfaces, no? In turn, you can no longer inject on that site. When we say lipoatrophy, mo na siya kanang mawala na gyud, no, or the decrease in size of your fat cells, no? So typically, if this is, let's say for example, the stomach, if you inject here, then you cannot inject here another time. You need to find another site. Ngari, inject ka dire. Dili na pwede, ngari na po ka, no? And then you need to keep moving. And then you need to rotate the side. Similar to diabetes. Okay? Monitor the patient's thyroid function. The way you monitor thyroid function is you can check the patient's T3, T4, and TSH levels, and gallbladder function. You know, gallbladder function is checked. Typically, it is checked by bile results. I think it's bile results. Yes. Oftentimes, the reason why you check is due to octreotide and lanreotide, no? Okay, you do not need to check it for bromocriptine, but for these two, you need to check thyroid and gallbladder function, because typically, they will increase thyroid function. They will increase thyroid function and they will decrease gallbladder function, no? So that's what's gonna happen with them. Okay, yellow. Next is our synthetic TSH replacement or TSH replacement. Okay, the action is synthetic TSH is used to diagnose hypothyroidism. TSH, it can also be used as TSH replacement in post-thyroidectomy thyroid cancer. Thyroid cancer, no? Post-thyroidectomy thyroid cancer. Na na siya, class, okay? Listen to me. Thyroidectomy, class, your thyroid looks like this. It's a butterfly-like organ, no? It's a butterfly-like organ. It's connected. Nasa sa imong neck. It's found in your neck, no? Typically, class, no? The reason why you get thyroidectomy is if there is a tumor like this, no? There is a tumor in your thyroid. Okay? Now, if there is a tumor in your thyroid, class, chances are there will be an increase in the thyroid hormones. Okay? There will be an increase in the thyroid hormones. Now, the thyroid hormones are caused, no? They are increased because there is an increase in TSH. Now, if nagani tumor, class, like this, no? The doctor will do a thyroidectomy. Meaning to say, tangtangon nila ang imong thyroid. They will remove your thyroid, no? Especially in cancer, di ba? Tumor man na, no? So, they will remove the side of thyroid that still has cancer. So you are left with one side of thyroid only. And because of that, class, no, listen to me, because of that, class, there will be a decrease, no? There will be a decrease in your thyroid hormones. There will be a decrease in your thyroid hormones. Nga naman, because there's only one thyroid left, di ba? There will be a decrease, no? So there will be a decrease in thyroid hormones. Now, if you remember from our feedback mechanism, no? remember from our feedback mechanism, since there is a decrease, our TSH will be increased by your pituitary glands. Okay? They will increase your TSH so that it will hopefully increase the thyroid hormones. Hopefully increase. No? However, sometimes, even if this is increased, it is still lacking. Kuwang gihapon. So, that's why we give a TSH replacement to further increase the TSH so that we can normalize the thyroid hormone. That is what happens, no, in thyroidectomy. Now, this is also used to diagnose hypothyroidism. Okay? There is one drug here. It's our thyrotropin or thyrotropar. Thyrotropin or thyrotropar. Now, I will show you how we use it in diagnosis. Okay? Now, in hypothyroidism, no, there are two types. We have our primary and our secondary. When we say primary, the problem is the thyroid. No, the thyroid cannot produce the hormone. Okay, the thyroid cannot produce hormones. Okay? If the problem is secondary, then the pituitary cannot produce TSH. Okay? Cannot produce TSH. Okay. Minaw mo na ako ha. And because of that class, because of hypothyroidism, there will be a decrease in T3 and T4. T3 and T4, these are our thyroid hormones. Okay. Now, initially, no, if mag-thyroid panel ka, what you will see is a decrease in T3 and T4, then you will just assume na siya hypothyroidism. You know that there's hypothyroidism, but you don't know if primary ba or secondary. You don't know if it's primary or secondary. So what do? You give the patient thyrotropin. Thyrotropin. Now, remember, thyrotropin is a synthetic TSH. Meaning to say, it will increase the TSH. It will increase the TSH. Now here, look. If, for example, you go back to your thyroid panel, no? And then you will see an increase in TSH but a decrease in T3 and T4, then that is primary hypothyroidism. Nga naman, we are giving the patient T3. Mo nang ni-increase. However, the thyroid itself cannot produce hormones. Therefore, the thyroid itself is not responding to the synthetic TSH. That's the reason why the T3 and T4 is still decreased. No? Still decreased. Kaya dili man mo respond ang thyroid. The thyroid does not respond to the increase in TSH. Okay? So that's primary. It means to say the problem is the thyroid. If, for example, the results are an increase in TSH or normal, and an increase in T3 and T4, then it means to say the problem is secondary. The problem is the pituitary. Because when you gave the patient their TSH, okay, when you give the patient the TSH, their T3 and T4 also increased. Meaning to say, the thyroid can make T3 and T4. However, the pituitary cannot make TSH. Okay? So that is how we differentiate, how we use this drug, no, to diagnose. Okay? So this is given, no? Here's our considerations. This is administered via IM only. Okay? This is contraindicated for patients with cardiac problems. The reason why is because, mamina muna ko ha, an increase in thyroid hormones, an increase in thyroid hormones can lead to what we call fast metabolism or increased metabolic rate. Ayan, metabolic rate, that is the technical term. And because of that class, it will increase substantially the patient's heart rate. No? So do not give this to a patient with cardiac problems, contraindicated. Educate the patient on the prescribed 2-dose regimen. Because two doses are needed to confirm diagnosis. Okay, 2 doses are needed to confirm the diagnosis. Okay? Okay, typically, this is given with a 12-hour interval. 12-hour interval. Inform patients that a TSH scan will be performed 48 hours after the second injection. No? TSH scan. Now, the reason why, no, this is to confirm if the TSH has been excreted by the body. Excreted by the body. Okay? And the reason why, class, is we don't want the TSH to stay. Because if the TSH stays, then it will just keep increasing the T3 and T4. It will just keep increasing the T3 and T4. Yung saka na pumayo, class, no? May mo na siyang hyperthyroidism. No? Because we don't want TSH to stay. Because it will lead to an increase in T3 and T4, which will eventually cause what we call hyperthyroidism. Hyperthyroidism. Okay, so we don't want that, no? And then we need to watch out for neurologic adverse effects like headaches, dizziness, stroke-like symptoms. We already know what to do with this, to implement fall precautions, instruct the patient to avoid driving and operating heavy machinery, diba? So we already know what to do with this. Balik-balik lang taan yung mga ani class, no? Next is our synthetic ACTH or ACTH replacement. Okay? So what are the actions? No, this will increase ACTH. ACTH is similar to your TSH, but instead of activating the thyroid, ACTH will activate the adrenals. Okay? This is used for diagnostic for adrenal versus pituitary hypoadrenalism. This is for treatment of hypoadrenalism. And this is also used as an anti-inflammatory treatment for allergic responses. Okay, we have 2 types of these drugs, no? Corticotropin and cosyntropin. Now, usually, class, I'm gonna emphasize that these two are used for the diagnosis of adrenal versus pituitary hypoadrenalism. So, it's very similar to this one, class, in hypothyroidism. Okay, so let us explain, no? There are 2 types of hypoadrenalism. We have our adrenal hypoadrenalism, wherein the problem is the adrenals or the adrenal cortex itself. Okay? And then we also have what we call our pituitary hypoadrenalism, wherein the problem is the pituitary or in the brain. Okay? Now, because of that, class, because of these 2, no? Remember, sa pituitary, there is a decrease in ACTH. Okay? Because of these 2, class, these 2 types of hypoadrenalism, no, they will cause a decrease in cortisol and aldosterone. Now, cortisol and aldosterone, class, these are our adrenal hormones. Okay, these are our adrenal hormones, specifically our adrenal cortex hormones, no? So if you look at an adrenal panel, no, what you will see is a decrease in cortisol and aldosterone. But you don't know if it is because of the adrenals or because of the pituitary. We don't know. So, we give them corticotropin. It is a synthetic ACTH. So, it is a man-made ACTH, no? It will increase ACTH. And because of that, you need to monitor the patient's ACTH and corticotropin hormone levels. No? And because of that, class, okay, listen to me, ha? If there is an increase in ACTH but a decrease in aldosterone and cortisol, it means to say, no, that the problem is the adrenals. Because we are giving the patient ACTH through our corticotropin. However, there is no increase in cortisol and aldosterone. It means to say, ang adrenals themselves cannot produce your cortisol and aldosterone. However, class, if both ACTH and cortisol and aldosterone are increased, then it is what we call our pituitary. Nga naman, it means to say our pituitary cannot produce ACTH. And because of that, when we give the patient synthetic ACTH, it will increase the ACTH and also produce cortisol and aldosterone. No? So, yan na siya. That is how we use it to diagnose. No? Now, for our nursing consideration class, listen to me. I did not put this here, no? It is spoiler alert for later. For our nursing considerations, it is similar to giving synthetic cortisol and aldosterone, which I will discuss later. So, watch out for that na lang. No, I don't want to be redundant, Mangod. Okay, so, it's like that. No, it's quite complicated, actually, I might say, no? That's why I'm emphasizing if you don't understand the ACTH, the T3, the T4, no, you feel free to stop and then go back. Feel free to kanang look back sa previous slides. No, you're already given the slides in advance, man. And you also have your notes, you also have your book, so feel free to read, no? But basically nga na siya, that's how we do it, no? Ay, nursing talaga. Okay, next is our oxytocin. You're very familiar with oxytocin because I'm not gonna argue with you, no? Oxytocin, it is used for labor augmentation by facilitating smooth muscle contraction in the muscles. Oxytocin, synthetically also known as our pitocin. Okay, pitocin. You already know this, no? Monisha, this will help the mother with their labor, no, by increasing the vaginal or the uterine contractions, no? So, if you are not familiar with this class, don't worry. The reason why I am summarizing this here is because you will have this in your maternal too. If you don't have this already, you will have this in your maternal too, no? Monitor the patient's FHR and the maternal BP and heart rate because an increase in uterine contractions can cause maternal and fetal distress. Maternal and fetal distress, di ba? So, monitor for signs of uterine rupture. What are signs of uterine rupture? Good, be sudden pain, no? Feeling of loss of pressure, no? What else? Sudden watery outflow, di ba? Use an IV pump when you are administering this class because we want a accurate dosing. Ayan. Prepare tocolytic agents. Tocolytic agents class are they are what we call uterine relaxants, no? Relaxants. And oxygen, readily. Oxygen is to alleviate, no, the fetal distress. So, don't worry class, I'm summarizing this to you right now so because ibalik pa magunis yung maternal, no? So let's continue. Next is our ADH drugs. Now there are two classifications of ADH drugs, but before we continue, no, let's talk about ADH. Now ADH promotes water reabsorption in the kidneys. And there are two diseases involved when it comes to our ADH. First is our hypersecretion, okay, called our SIAD or syndrome of inappropriate ADH. When we say syndrome of inappropriate ADH class, there is too much ADH. Daghan kaayo og ADH. And because of that class, there's too much ADH, there's too much antidiuretic hormone. Then there is water retention. Okay? Ngano na may water retention? Why is there water retention? Because there will be a decrease in urine output. Listen to me ha. There is water retention because there is decrease in urine output. Ngayon, why is there a decrease in urine output? Remember, this is an anti-diuretic. It will prevent you from urinating. It will prevent you from urinating because it will reabsorb the water. Diba? And if there is too much of this, then there is too much water reabsorption. So there is water retention. There is decreased urine output. Because, listen to me ha, because there is too much water, your blood will become less concentrated. It will become diluted. No? Because there is too much water retention, your sodium will also decrease. This is what we call our dilutional hyponatremia. Now, what do I mean by that? What's yung pasabot na, sir? What does dilutional hyponatremia mean? No? Let's say, for example, class, this is two instances, okay? And then, let's say, for example, this is your sodium. Let's say, naatay 5 ka buok cell. No? Let's say, there's 5 cells. Ay, bati man ako pagka-drawing class. Wait sa, ito tarungon. We can just copy this. Okay, ayan. Oh. Now, listen. No? If, for example, ako na lang i-green. Bati man ang blue day. Yeah, ayan. No? No? If, for example, class, normal, this is the blood level. Okay, this is the blood level. Now, if I am gonna take, no, that sample, no, the sodium level remains the same. However, the water level is also constant. Okay? Class, if for example, class, there is water retention, then there is too much water in the body. Now, if I take the same sample, class, no? If I take the same sample, okay, the water is increased, but the sodium is the same. And in turn, class, no, kini mo sodium, it will be diluted. Okay, ma-dilute na siya, class. It will mix with too much water. No, it will be diluted. So this is for Sayad. Okay, ha? It will be diluted because there's too much water. And because of that, class, no, relatively speaking, in the same amount or the same volume of or container of fluid, technically, you will have a decrease in sodium here because, tanawa, this volume does not have sodium while this one has a lot of sodium. Okay? Okay? But you are measuring them as one. So, relatively speaking, there's little sodium. Whereas, no, in the normal body, since there is a normal amount of fluids, then, technically speaking, if you are gonna measure this, then there will also be a normal amount of sodium. Whereas if I measure something like this, no, then there is very little sodium relative to the size of the container. That is how best I can describe this, no. There are better ways to describe this, class, but the better ways are much more complicated, no. There is an increase in urine specific gravity and an increase in urine osmolality because, no, there is a decrease in water, meaning to say your urine is more concentrated. Okay, there is swelling and increased BP. The treatment of Sayad revolves around inhibiting the production of ADH, inhibiting or stopping the production of ADH because there is too much ADH. Okay? We also have our DI. Okay, DI, diabetes insipidus. So, inadin nila in classes sa diabetes, or yes, there is DI. Okay? Now, in diabetes insipidus, class, it is the opposite. There is a decrease in ADH. Okay? Decrease in ADH. And because there is a decrease in ADH, class, there is a decrease in antidiuretic hormone, there is an increase in urine output. And because of the decrease in ADH, class, there will be a decrease in water reabsorption leading to water secretion. Daghan na no mugawas. There's a lot of water that will go out of the body na because they are not being reabsorbed, they are being excreted, no? Because of that, the blood concentration will increase because there is less fluids. So there's more blood, no? There's more blood products. There will be an increase in sodium. The reason why there is an increase in sodium is because if you eliminate lots of water, then what's left is sodium. Diba? What's left is sodium, so hypernatremia. There will be a decrease in urine specific gravity and urine osmolality. The reason why there is a decrease in specific gravity and osmolality is because since you are urinating lots of water, you're urinating lots of water, the urine is not concentrated. It's not concentrated, so it's not heavy, it's not full of electrolytes, it has decreased osmolarity because it's not concentrated, no? And then it will cause dehydration and a decrease in BP. Decrease in BP because there is a decrease in overall fluid volume. Remember, if decreased gani ang yung fluid volume, there is a decrease in preload, there is a decrease in cardiac output, which will cause a decrease in BP. And vice versa. If there is an increase in fluid volume, then there is an increase in preload, an increase in cardiac output, which will increase your blood pressure, no? So the treatment of DI revolves around stimulating the production of ADH or replacing ADH altogether. Replacing ADH altogether. Okay? So let's start with our drugs for SIAD, no? We have two types. We have our ADH inhibitors, no? ADH inhibitors, and we have drugs that will reverse the hyponatremia. Okay? Now, our ADH inhibitor class, we have our demeclocycline. Demeclocycline class is also a tetracycline. Ha? It's also a tetracycline. So, muna nakaamaw ano yung mga tambal class, no? So, what do you need to remember when it comes to these drugs? Now, what do you need to remember when it comes to these drugs? Now, these drugs class, lagyan mo yan ng malaking star. This is nephrotoxic, no? Similar to other tetracyclines, it is nephrotoxic, no? Another thing you need to remember is you need to watch out for photosensitivity. Photosensitivity. Ayan, no? And this is contraindicated for pregnant patients and children under 8 years old. Nga naman. Okay? Children under 8 years old. Why? Because this drug can inhibit bone growth and it will also cause tooth discoloration that is permanent. Okay, so bantayan na ninyo siya, class demeclocycline. Our conivaptan and tolvaptan, these are hyponatremia reversal drugs. What they do, mga good class, is they will block ADH receptors, no? They will block ADH receptors, no? And because you are blocking the ADH receptors, class, then they will normalize, no? Normalize urine output, which in turn will cause reversal of hyponatremia. Okay, hyponatremia. So muna siya conivaptan and tolvaptan. Okay, so what are our nursing considerations for drugs like this? What are our nursing considerations for drugs like this? First is strict monitoring of serum sodium levels. I'm gonna highlight that. Lagyan ko yan malaking star class, no? When I say strict class, dapat strict din class, strict monitoring of sodium levels. Okay, strict monitoring. Nga naman, okay, remember ha, in our SIAD, there is hyponatremia. And we want to reverse that. Okay, we want to reverse that. Gusto ta nga mo normalize ang hyponatremia. Now, here's the thing. Overt, rapid correction of hyponatremia, meaning to say, class, if you correct hyponatremia very fast, paspasunin mo correct. Gusto ka nga ang low mo, diretsog normal. No. You have to do it slowly. Okay? Because overt rapid correction of hyponatremia can lead to severe neurologic damage. Neurological damage. Okay? And as such, class, and as such, no, you need to perform routine neurological assessment. Okay? For those of you who don't know what neurological assessment is, mao ni siya ang atong most of the time this is our assessment of the head. From your health assessment, no? Katong assessment of the cranial nerves, assessment of balance. So that's it, neurological assessment, no? It will also include, no, katong assessment of orientation. Typically we monitor neuro assessment, or we do neuro assessment every 6 hours. Okay? For first 24 hours of administration. Okay? Ayan. Monitor neuro assessment for first 24 hours or 6 hours. For first 24 hours every 6 hours. Monitor intake and output and vital signs. The reason why we need to monitor intake and output is because since these are drugs that will inhibit ADH, no? If you decrease ADH, no, if you decrease ADH with these drugs, then it might cause diabetes insipidus or diabetes insipidus. Like symptoms, no? DI-like symptoms. This will include our dehydration, diba? Dehydration and decreased blood pressure, no? So that's why you need to monitor for intake and output and vital signs. It's quite obvious, my good class. It's quite obvious, no? If you take a drug that will stop ADH, okay, then even though SIAD, listen to me, SIAD has an increase in ADH. However, in order to stop the SIAD or alleviate the SIAD, we will give a drug that will, okay, decrease the ADH. Pero class, listen to me, if masobraan na siya, class, if there is overdose, then that might lead to diabetes insipidus like symptoms. Diba? Because a decrease in ADH is just DI. No? It's just gonna be the opposite. No? If you do something that is too much, then it might become the opposite. Diba? Because of the effect of the drug. No? You need to implement seizure precautions, because when I talked about severe neurologic damage, I am referring to seizures. No? So seizure prec, I have already discussed this before, seizure prec. Okay? And then watch out for hypernatremia. As I mentioned before, no, a decrease in ADH. Okay, a decrease in ADH can increase urination. Okay, tanaw. A decrease in ADH can increase urination, but it will increase sodium as well. No, so you need to watch out for hypernatremia. Okay? Hypernatremia, which is greater than 145 milliequivalents per liter. Now we have drugs for diabetes insipidus, no? When we say drugs for diabetes insipidus, this is done to retain fluids. Remember, ang problema sa diabetes insipidus is that there is a decrease in ADH. So what we want is synthetic ADH to increase our ADH. Muna siyang i-action class to replace the ADH that is missing or lost, di ba? Or kuwang, no? Or lacking, di ba? So we have two. We have our desmopressin acetate or DDAVP and our vasopressin or pitricin. Okay? Now these synthetic ADH drugs, they are usually administered, Okay, administered intranasally or by injection. Okay? Kinesia class, this one here, this one is the intranasal. This one is the vial for injection. Kung nangilad ko ninyo, desmopressin. Desmopressin. Ayan. Oh. Desmopressin acetate. Oh. I'm not lying to you, class, no? Ayan. Sasabay ka ba? Papasa ka ba? What is your goal? To top the board exam. Okay. So, what do you need to remember when it comes to these drugs, no? As I mentioned before, these are replacement drugs. They will replace the missing ADH in your diabetes insipidus. So, you need to monitor the fluid and electrolyte balance, especially sodium levels. Nga naman, because when you increase your ADH, it is just like getting SIAD. It is just like getting SIAD, no? So you need to monitor the sodium levels because there might be hyponatremia. Okay? And since you are increasing the ADH, remember, an increase in ADH means a decrease in urine output. Okay? So, there might be rapid weight gain and edema. Okay? This is contraindicated. Lagyan mo yan ng malaking star, class. Malaking star talaga, class. In patients with severe renal impairment, what do you need to do, good class? You need to check the patient's creatinine and BUN. Okay, when we say severe renal impairment, class, typically ang CREA ug BUN very, very increased. Okay, CREA and BUN very increased. Okay, so we need to monitor the patient's renal status while giving this drug, and the reason why, no? And the reason why we need to avoid giving it to a patient with severe renal impairment is because, no, if you give an increase in ADH, it will overwhelm. Okay, it will overwhelm the kidneys. And if your kidneys are severely damaged, then it might be very, very bad. Okay. Restrict fluids when giving this drug. This is to prevent fluid overload. Now, in fluid overload, class, what happens is there will be an increase in blood pressure, a decrease in heart rate. Okay, there is a high chance for edema. What else? No, what else? There is a high chance for edema, pulmonary edema, and mostly kana magid ang mga common. That's the common idiosyncrasies. Restrict fluids. Because when you give ADH, there is decreased urine output because there is fluid retention. You need to say, daghan kayo, there's too much fluid in your body, and that's why we don't want to give them more fluids. Okay? And monitor the patient's vital signs because, as I mentioned before, it might increase the BP and heart rate. It might increase the BP and heart rate. That's the keyword there, might. No, the keyword here is might. No? Okay, so next is the thyroid and parathyroid drugs. Now, these are drugs used for hyperthyroidism, hypothyroidism, hyperparathyroidism, and hypoparathyroidism. Now, before we discuss the specific drugs, let's talk about the hormones first. Okay, so the controller here is our TSH for our thyroid and our serum calcium levels for our parathyroid. Now listen, ha? The TSH will stimulate the thyroid to release triiodothyronine, or also known as your T3, and thyroxine, or T4, also known as your tetraiodothyronine. Now, the key part here is this. Now, I want to highlight this. There is iodo. Okay, iodo. That is because, class, the key component when it comes to your thyroid gland drugs is your iodine. Okay, iodine. Now listen. Okay, listen. The T3 and T4, their target is systemic, meaning to say they will target the entire body. No? And their effect is to regulate metabolism. Listen ha, their effect is to regulate metabolism. And for T4, no, also heat production, body heat. Okay, body heat. What I mean by regulate metabolism is this. Metabolism, if you remember, it is the chemical processes in our body. No, so it consists of anabolism and catabolism. No, so the synthesis and the breakdown of specific chemical and cellular components of the body. So, for example, class, if there is an increase in T3 and T4, like for example in your hyperthyroidism, then there will be an increase in metabolism. Okay, and then if there is an increase in metabolism, then everything is increased. Okay, everything is increased. The other thing that it releases, the thyroid releases, is calcitonin, the other hormone. Calcitonin targets the kidneys, and they will promote renal excretion of calcium, thus decreasing serum calcium. It works, class, in conjunction. Your calcitonin works in conjunction with your parathormone, released by your parathyroid hormone. Okay? Your parathormone, class, affects the bones or targets the bones, wherein it will promote movement of calcium from the bones to the blood, thus increasing your serum calcium. These two together will participate, no, in the regulation of calcium in the blood. That is the reason why it is controlled by our serum calcium levels. It is through a feedback mechanism, no? So for example, if there is a decrease in serum calcium, then the body will react by increasing parathyroid hormone, because parathyroid hormone will increase serum calcium. And for example, if there is increase in calcium, then the body will secrete, no, calcitonin, because calcitonin decreases serum calcium, so it's just pushing it back to normal. Okay, so here's a comparison of our thyroid disorders. No, thyroid disorders typically, when we're talking about thyroid disorders, this just affects T3 and T4, not really calcitonin, no? In hypersecretion, in class, we call that our Graves' disease or Graves' hyperthyroidism or hyperthyroidism. In hyperthyroidism, class, there is an increase in T3 and T4, meaning to say there will be an increase in metabolism. So the patient will have fatigue, weight loss. Weight loss, class, is because if you are metabolizing, no, digestion is very fast, absorption is very fast, excretion is also very fast, di ba? Heat intolerance, because there is increased T4, so your body is more hot, so you will not be able to tolerate more heat. Exophthalmos is called the bulging of the eyes. Okay. Fast heart rate, diarrhea, because as I mentioned before, an increase in metabolism. Okay, an increase in metabolism will also increase, no, digestion and the processing of food, no. Nervousness, because an increase in metabolism will also increase CNS action. And goiter. Goiter is an enlargement of your thyroid gland. Okay? So, nganin na siya, class. Typically, the treatment of Graves' disease or hyperthyroidism revolves around inhibiting the production of T3 and T4. So, we will stop the production of T3 and T4. While on the other side, class, we have Hashimoto's thyroiditis, also known as Hashimoto's hypothyroidism, also known as your hypothyroidism. This is hyposecretion, meaning to say there will be a decrease in T3 and T4. Okay? There will be a decrease in T3 and T4, no? So, typically, what happens is you will feel fatigue. Same gapon, you will feel fatigue because metabolism is very low. There will be decreased metabolism ba yan, di ba? Metabolism. There will be weight gain. Lagyan mo yan ng malaking star. There will be weight gain because the slower your metabolism is, the slower it will take for you to burn your fats. Okay? Or to excrete your fluids, to excrete your fats. That's why there is weight gain. Okay? Cold intolerance, that is because of the decrease in T4. Puffy face or slow heart rate, constipation, depression, and goiter. All of them are characteristics of a slow metabolism, no? And the treatment revolves around the stimulation or stimulating the production of T3 and T4. So we want to increase, no? T3 and T4. Whereas in hyperthyroidism, gusto ta, we want to decrease the T3 and T4. Now, the drugs for hyperthyroidism usually inhibit the production of T3 and T4, while the drugs for hypothyroidism synthetically replace inadequate T3 and T4. Balik-balik na lang tayo na class, no? Replacement and or inhibition, and replacement and inhibition. Okay? So, these are the drugs for hypothyroidism. Okay? When we say hypothyroidism, remember there is a decrease in T3 and T4, our triiodothyronine and our tetraiodothyronine. So our thyroid hormone replacement drugs, their effect is to increase the T3 and T4. Very self-explanatory, no? Very easy to understand. Okay? The first is levothyroxine. Now, levothyroxine class, no, this is the drug of choice, no? Drug of choice for hypothyroidism. Hypothyroidism. Okay? Why? Because it increases both T3 and T4. It increases both T3 and T4. This can also be used to treat simple goiters. Now, I will not discuss simple goiters, so that is for your MS. But lagyan mo yan ng malaking star class, okay? Lagyan mo yan ng malaking star. Liothyronine is synthetic T3 only. Synthetic T3. So, it does not have, no, T4. However, class, no, this will have a short half-life. If you remember half-life, diba? And duration. It will have a short half-life and duration. So, this is not good, no? This is not for maintenance. Dili na siya. This is not for long-term maintenance because of the short half-life. However, this is the initial drug. Initial drug for mixed edema. Now, mixed edema class, no, this is what we call a complicated hypothyroidism. Complicated or aggravated, nanubra, or severe aggravated hypothyroidism. Okay? Aggravated, no? Typically, class, liothyronine is given per orem. Given per orem. No? Leotrix class is just a mixture of both levothyroxine and liothyronine, no? There's no benefit to using Leotrix over levothyroxine or liothyronine independently. However, this is just an option, di ba? This is just an option. Mo man na siya ikuan class. That is the nature of medicine. It's about more options, manggod. The more options, the better, di ba? That's the nature of medicine. So what do we need to consider when we are giving these drugs? Now, these drugs can increase metabolic rate, cardiac output, and glycogen use. As such, it is important to check TSH levels prior to and after administration. Okay? We want to give this class. We want to give this if TSH is decreased. Okay? You have to give this if the TSH is decreased. However, class, listen to me, ha? Listen to me. That would be your initial impression, no? That will be your initial impression. Okay? Actually, class, we give if decreased ang imong TSH or give if increased ang TSH. Why? Okay, why? Remember, if your TSH is decreased, that could be secondary hypothyroidism, di ba? If the TSH is increased, then that is primary hypothyroidism, di ba? Hypothyroidism, okay? The reason why we check the TSH levels, no, prior to and after administration is we want to see if there is an effect, no, to check drug effect, di ba? Okay, we need to monitor for signs of over replacement. We need to say over replacement because overdosage, no? So we need to check for signs and symptoms of hyperthyroidism, di ba? Because if we give too much of these thyroid hormone replacement drugs, then it will increase T3 and T4. An increase in T3 and T4 is similar to hyperthyroidism, di ba? So we need to check for tachycardia, palpitations, heat intolerance, and weight loss, no? We need to monitor another thing is if there are symptoms of hyperthyroidism, then you need to report this to the MD, the doctor, no? You need to report this to the MD. You need to monitor blood glucose levels as well, because this will also affect increased glycogen use. Typically, the blood glucose will be decreased, no, when you are giving these drugs. And take the same time every day before breakfast. Okay, the keyword here is before breakfast. Nga naman, because food will affect absorption rate of these drugs. Food will affect absorption rate of these drugs, no? The reason why we want same time every day, especially for hormones, no, is we want consistent delivery. Muna siya key class, consistent delivery, no? Meaning to say, class, if you give these drugs, if you give replacement drugs, it must follow the normal cycle of the drug or the hormone in the body naturally, no? You need to emphasize that this is a lifelong treatment. When we say lifelong, class, this is for life, no? Lifelong treatment, life sentence yan, class, no? So, the reason why we need to emphasize that because sometimes they stop taking these drugs, no? So, lifelong ni siya, class, because you need to replace the thyroid hormones for life. What else? Check the drug-to-drug interactions. When you are giving this with anticoagulants, there will be an increase in bleeding risk because this will affect, no, thyroid hormones will affect coagulation. Increased CNS and cardiac effect of adrenergic agents when you are giving these drugs with adrenergic agents. Decreased effectiveness when given with digoxin. Insulin and diabetic drugs may have their doses adjusted with this drug because remember, this will affect glycogen use, no? So keep that in mind, okay? Keep in mind unsa na siya, increased ba na siya or decreased ba na siya, because that might come relevant, no, in your exams, no? Next is our drugs for hyperthyroidism, also known as our antithyroids. Now, hyperthyroidism, class, there will be an increase in T3 and T4, no? T3 and T4. Now, our antithyroids, class, their action is to decrease T3 and T4. Now, there are two classifications, class. Listen to me, ha. There are two classifications. First is our thioamine derivatives. They will decrease thyroid production. That is their action, ha. They will decrease thyroid production, no? Now, there are two, propyl thiouracil and tapazole or methimazole, no? These drugs, class, are effective at treating thyrotoxicosis When we say thyrotoxicosis class, this is aggravated hyperthyroidism. Okay, aggravated hyperthyroidism. No? Okay. The key, another thing you need to remember about this drug is prolonged use. Prolonged use may cause goiter. Okay? Prolonged use may cause goiter due to increased TSH secretion and inhibited T3 and T4 synthesis. Okay? Synthesis, no? So, these drugs, mga good class, they will inhibit, no, your TSH and they will inhibit the creation of T3 and T4, no? So, it may cause goiter. Goiter, mas common, mga good class. Goiter is much more common in hypothyroidism than in hyper, no? It still happens in hyper, but it's more common in hypo. Okay? Next is our iodide preparations, our potassium iodide or Lugol solution. They are used to suppress thyroid function. When we say suppress thyroid function, decrease functioning. No? So, the main purpose of our Lugol solution class is to suppress thyroid function. Okay? Post-thyroidectomy. As I mentioned before, if mag-thyroidectomy ka class, if you have a thyroidectomy, they will remove part of your thyroid, di ba? They will remove 1/2 of your thyroid or 1/4 or your entire thyroid. But they will keep a portion of it na naturally mabiling yung thyroid kasi they will not remove the entire thyroid. And because of that class, that small portion of thyroid, it will have what we call rebound production of T3 and T4. And kana siya class that will cause hyperthyroidism. Okay? Hyperthyroids. wait. Tarongon. Hyperthyroidism, di ba? And the key here is this, no? If thyroidectomy is usually indicated if there is hyperthyroidism. If the hyperthyroidism, there is a tumor, it causes hyperthyroidism, then mag-thyroidectomy ka, you need to remove the thyroid. Once you remove the thyroid, that portion that is remaining will rebound, produce T3 and T4, and lead to another hyperthyroidism. So that's when you will give them your Lugol solution, because the Lugols will suppress or slow down thyroid function. Okay? Suppress or slow down thyroid function. Another is this is also used to decrease vascularity prior to thyroidectomy. Okay? Ang kanang mo imong thyroid class, your thyroid gland, it's very vascularized. Meaning to say, class, there's lots of blood vessels going into and out of your thyroid gland, no? So, you give Lugol solution before the thyroidectomy so that there will be a decrease in blood flow towards your thyroid, causing less blood loss during surgery. And we want that, di ba? We want there to be less blood loss during surgery. Now, the key here is this. Lagyan mo yan ng malaking star. Okay? This is an iodine type of solution. Okay? Iodine type of solution. So, you need to assess for allergy. Okay? Ayun sa ha? Okay, assess for allergy. Now, how do you assess for allergy when it comes to iodine? No, very simple class. Ask the patient if they are allergic to shellfish. Okay? Shellfish or oyster. Kana. Because if they are allergic to either of them, they are also allergic to iodine because both of them are rich in iodine. Okay. Okay, ayan, lagyan mo yan ng malaking star, class. Pwede po ka mangutan na class, or you can also ask them if they are allergic to iodine itself. Di ba? Mama, you allergic to iodine? Maybe they already know, no? But most of the time, this is your question. Okay, basta iodine-like solutions, no? So what do we need to remember about these drugs? Nursing considerations for this hyperthyroid, anti-hyperthyroidism or anti-thyroid drugs include instruct the patient to take these drugs with meals. This is to avoid GI irritation. Okay? Emphasize the need to follow regimen. Nga naman, emphasize the need to follow the regimen, the drug regimen. Nga naman, abruptly stopping. Okay, abruptly stopping anti-thyroid drugs could cause thyroid crisis. Okay? Thyroid crisis, no? Watch out for signs of over-suppression. Remember, these are drugs that suppress. So, signs and symptoms of hypothyroidism, same gihapon kasi you need to report, no? If you are over-suppressing, no, it might cause hypothyroidism or hypothyroidism-like symptoms, no? Which includes low pulse, cold intolerance, weight gain, and the lack of perspiration or sweating. Okay? And this is contraindicated in patients who are pregnant. Lagyan mo yun ng malaking star, class. They often forget about this, no? Especially kining imong methimazole. Okay? Methimazole, no? Is that familiar, class? Okay? Methimazole, is it familiar? Methimazole. Now, don't go na don't what do you call this? Don't be alarmed, ha? There's azole there. Now, you might think, no, that azole, methimazole, is an antifungal. Okay? You might think that this is an antifungal. No, class, it does not follow, no, your azoles, no? It does not follow your azoles. It is just named methimazole. Methimazole, class, is not an antifungal. It is just an anti-thyroid agent, even though it is named like an antifungal. Okay, there are drugs like that, class, who do not follow the nomenclature. Okay? Next is our parathyroid disorders. Parathyroid. Okay, parathyroid. Para sa iyo. Ang laban at su. Okay, our parathyroid disorders, no? There are two. We have our hyperparathyroidism. Now, in hyperparathyroidism, there is an increase in parathormone or PTH, no? Parathormone. Now, remember, ha? For you to never forget, class, PTH. Okay? PTH, parathyroid hormone. Okay? Para sa blood. Meaning to say, there will be an increase in calcium in the blood. Okay? Parathormone, para sa blood. There will be an increase in calcium in the blood. Because of that, no? Tanaw ha, listen to me ha. Ingani mo na siya, class. Your parathormone, if you remember, tanaw, it works by moving calcium from the bones to the blood. Okay? It works by moving calcium from the bones to the blood. Now, if this is your bone, okay? Hugawag utok ni mo, God, no? This is your bone. Calcium is moving. Okay, calcium is moving from the blood, from the bone towards the blood. So calcium here will be increased, while the calcium here in the bones will be decreased. No, there will be a decrease in calcium. Remember, calcium is stored in your bones, diba? Now, if there is an increase in calcium in the blood, there will also be a decrease in calcium in the bone. Now, why is this relevant? Listen, ha. An increase in serum calcium greater than 11 milligrams per deciliter will cause constipation. Okay? Because an increase in calcium will cause constipation in the blood, no? An increase in calcium in the blood will cause constipation. Bone pain. The reason why there is bone pain, okay, the reason why there is bone pain, and specifically a risk for fractures, is because of the decrease in calcium in the bone. Okay? This will cause your calcium this will cause your bone to lose density. Okay, if there is a decrease in calcium in the bone. So that's why there is bone pain. That's why there is a risk for fractures. There is also a risk for kidney stones as well, because an increase in calcium in the blood will eventually go to your kidneys. And your kidneys might get overwhelmed and they might turn it into stones. Okay, and dysrhythmias, no? If you remember, no, an increase in calcium will increase the contractility of the heart, di ba? No? So the treatment of hyperparathyroidism revolves around inhibiting the production of PTH. Okay? For our hyposecretion, we have hypoparathyroidism, wherein there is a decrease in parathyroid hormone. Okay? If there is a decrease in parathyroid hormone, there is a decreased calcium in the blood, but there is an increased calcium in bone. Ayan. Increased calcium in bone, no? So there will be a decrease in serum calcium less than 9 milligrams per deciliter. This will cause dysrhythmias as well, because a decrease in calcium can also slow down your what we call cardiac contractility, severe muscle spasms, because actually, class, no, the two major signs of hypocalcemia. Okay? Hypocalcemia man, class, di ba? Decrease in serum calcium. Whereas an increase in serum calcium is hypercalcemia. The major sign of hypocalcemia is your Schwostek's and Trousseau's sign. Okay? Sige lang, you will know more about that in your MS. Just keep that in mind, no? It will also cause seizures, hyperactive reflexes, okay, and a tingling sensation, no? Basically, because hypocalcemia, most of the time, it revolves around involuntary muscle control, diba? As you can see, no, muscle spasms, seizures, hyperactive reflexes, these are just involuntary muscle control, no? So the treatment of hypoparathyroidism revolves around stimulating the production of PTH. Stimulating the production of your PTH. Now, here are our drugs for hyperparathyroidism. Remember the problem with hypoparathyroidism is that there will be a decrease in serum calcium. Meaning to say, there is a decrease calcium in your blood, no? So what we need to do is we need to give them vitamin D analogs. Vitamin D analogs promote calcium absorption from the GI and secretion of calcium from the bone to the bloodstream. Therefore, it will increase calcium in the blood. Okay? There are two, calcitriol and ergocalcitriol. Rocaltrol, and Drisdol. Drisdol. Okay. So, wala siya hyperparathyroidism, no? So, it's very common. High vitamin D analogs. Okay? Now, naturally, class, no? Naturally, where do you get vitamin D? Naturally, Vitamin D is from sunlight. Ayan, sunlight, no? UV light. Okay? Drugs for hyperparathyroidism. Remember, the problem with hyperparathyroidism is there will be a what? There will be a increase in serum calcium. Okay? Or calcium in the blood. No? There will be an increase. Daghang kay calcium. So what they do is this. They will inhibit osteoclast-mediated bone resorption, which decreases the release of calcium from the bone into the blood. Okay? Now, maingon ka na ako, sir, that's too medical, sir. Tang ina nandito ka na naman. Osteoclast. Okay, remember, if you remember from your anatomy and physiology, they will break down bone. Break down bone. Now, if you break down bone, class, they will release calcium. And then, where is that calcium going to go? To your blood. Because there's nowhere to go, nowhere else to go but your blood. No? So, these drugs will inhibit osteoclast-mediated bone resorption. When we say bone resorption, it is the movement of calcium from the bone towards the blood. Okay? So, it will inhibit, it will stop the breakdown of bone. Therefore, stopping the release of calcium and stopping the calcium from going to your blood. Okay, so there are 3 drugs here. We have our calcitonin, etidronate, and our cinacalcet or Sensipar. Okay? Now, mo ni siya akong gusto buhaton ninyo. I don't want all of the work for myself. No? I don't want all the work for myself. So, what I want you to do is this. There is a further reading. Okay? I want you to further read on the nursing considerations of the drugs for hyperparathyroid and hypoparathyroid drugs. Okay, ni silang duha. Read on the nursing considerations because I'm also including this in the exam. Okay? However, class, naapod tayo assignment. Okay? Ang assignment, class, it must be typed. It must be in a PDF format. Okay? And listen to me, the deadline, and I'm emphasizing, the deadline is a deadline for a reason. I will not accept if you do not pass it on the deadline. Okay? I will not accept. Di ko mo dawat, class. Okay? The deadline, class, 0 na ka diretso, if di ka kapasa, is November. What's a good date? November 14, 2025, 11:59 p.m. Sharo. Okay? Now, what will you do in your assignment? You will do 2 things. You will make a drug summary of any of the semifinals drugs. So, you can use an anti-respiratory drug. You can use an ANS drug. You can use a respiratory drug, ANS drug. You can even use an endocrine drug. Okay? Bahala mo. Just one drug. Okay? I want you to follow the format. Sabihin na muna ako, follow the format. The UV format. Kato akong gihatag before. No? You already have a copy. Okay? And then, in the next page, I want you to make a comparison table of the nursing considerations of hyperparathyroid and hypoparathyroid drug nursing considerations. So, inyaray mo na yung table, comparison table, no? Lagyan ko yan ng malaking star, class, no? This is all 10 points ni siya, class, and the next one is also 10 points. I'm emphasizing this because I want you to make a comparison table again, no? And I want you to upload it as a single PDF. So, usara ka PDF, do not upload 2. If you upload 2, zerohan ko na diretso, no? It must be no greater than 10 megabytes. So, dili pwede mag-send kag picture, class, send a PDF, okay? You can upload the PDF on the following link. So, if you have, actually, you can click this, and it will open, no? If you have access to the PowerPoint, you can just click this, and it will immediately open. Click this to go to link, or you can scan the QR code, okay? or you can scan the QR code. Moderno na ta class, di ba? Moderno na ta, scan the QR code. And I will mention this again. The deadline is November 14. Okay, November 14. Yan. Okay, basig na siya mingon ako, sir, wala ko kapas, sir, bahala ka diha. Okay? It is not my job to be responsible. It is your job. My job is to teach. No? And speaking of teaching, we have now reached our final discussion for today. Our adrenocortical drugs. Maglibog yung ni class, adrenocortical drugs. No, maglibog sultian ni class, no? These are cortical replacement drugs. Now, kayo ka na ko, sir, nga no, cortical replacement man, sir. And why isn't there inhibiting drugs? Okay? I will now teach you why there are no inhibiting drugs. Inaon ta mo, tudloan ta mo. Okay? You will learn later. Okay, so it's like this. Now, let's talk about the hormones first. Now, class, listen to me, ha? I would say this is quite complicated, no? There are two adrenals. Okay, listen to me, ha? There are two adrenals, no? We have our adrenal cortex and our adrenal medulla. Okay, now we will not talk about the adrenal medulla. The adrenal medulla, class, is quite simple, no? It will secrete epinephrine and norepinephrine. I don't need to discuss this anymore because we've already discussed this a lot. Like, sige na tag-discuss sa the class, I don't need to discuss this anymore. And this is not, we're not gonna discuss the drugs here anyway because we've already discussed this in your adrenergic and cholinergic drugs, no? ANS drugs. So technically speaking, those drugs were also endocrine drugs, no? So that you don't forget, class, so that you don't forget the adrenal medulla hormones. Just remember, class, every time you hear adrenal medulla, always be thankful for the Lord and Savior, no, Jesus Christ. What do you say? Diba you say amen? Diba you say amen, class? No? The reason why you say amen is because A means adrenal medulla secretes epinephrine and norepinephrine. Okay? Say amen, class, ha? So that during the exam, you will not forget. No, amen. Thank you, Lord, for giving me the answer to the exam. So let's not focus on that medulla. Let's focus on the ACT, the adrenal cortex. Now, the cortex, class, okay? Oftentimes, no? Listen to me. They secrete three hormones. Okay? They will secrete the mineralocorticoids. Ayan. The glucocorticoid and the androgen. Now, let's focus on these two, mineralo and glucocorticoids. Androgen, mga class, no? They are part of the reproductive system. They will target the gonads, which will cause the development of secondary sex characteristics, specifically in males, no, and for growth and development of the females, no. So mo gini affect this its effect. Let's not focus on that, okay? Our adrenal cortex is controlled by our ACTH. However, our mineralocorticoid is controlled by our RAAS, di ba? Renin, angiotensin, aldosterone, di ba? If you look here, another name for your mineralocorticoid is aldosterone. That's why it's controlled by your RAAS. While your glucocorticoid is still being controlled by your ACTH. So an increase in ACTH will increase your glucocorticoid, also known as your cortisol, di ba? Now, the thing that they always teach us, no, in the board exam class, para dili na makalimot, how can you not forget the adrenal cortex, that hormones? Just remember, class, adrenal cortex hormones, class, are just SSS. Okay, SSS. Nga naman. SSS. S in our mineralocorticoids stands for salt. S in our glucocorticoid, from the name itself, mineralocorticoid has salt. Glucocorticoid stands for sugar, glucose, sugar. S in our androgen stands for sex. Adrenal cortex, SSS, salt, sugar, sex. No? Ano sex man? Because it develops secondary sex characteristics. Okay? Now, balikta. Balikta, we're not done yet, no? There are two hormones that we call our corticosteroids. Okay? Meaning to say, class, they are steroids released by your cortex. We have our mineralocorticoid, which is our first corticosteroid, and our glucocorticoid, our second corticosteroid. Now, our corticosteroid class, they have similar effects. Now, they have a quite shared effects. No, both corticosteroids will promote sodium retention and promote potassium excretion. So there will be an increase in sodium and a decrease in potassium and water retention. So there will be an increase in sodium, water, no? However, class, they also have isolated single effects. Like, for example, our mineralocorticoids will promote the reabsorption of sodium. That's why it's called salt, because it will increase sodium. And the retention of water, it will also increase water. Muna siya yung main effect, okay? Our glucocorticoid, though, is the one with many effects, okay? Our cortisol, class, and I want you to remember this, halagyan mo yan ng malaking star. Okay, our cortisol is our stress hormone. Typically, this will increase when there is stress. Okay? Now, the problem here is that we don't know what stress is. Diba? Okay? We don't know what stress is, no? I just want to get this clear. Okay? Ang inyo magong pagsabot sa stress, class, the way you understand stress is psychological and mental stress, no? Stress is not like that, class, no? It is non-specific, no? According to Hans Selye, I don't know if you know Hans Selye from your fundamentals of nursing, stress is a non-specific. It is a non-specific response of the body. And here is the keyword, to any. Kana mo na keyword, any demand. Meaning to say, if you are tired, that is stress. Okay, if you are feeling unwell, that is stress. If you are nauseated, that is stress, because your body is being put to an intensive demand, and stress is just your response to that demand. Okay, so this is the stress hormone. Now, the stress hormone is quite amazing, no? It will increase serum glucose because you need more glucose when dealing with stress. You need more energy. That's why it's called a glucocorticoid, no? It has anti-inflammatory effects, anti-allergy effects, suppression of the immune system. It will slow down or stop your immune system, and anti-stress effects. Lagyan mo yan ng malaking star, no? Kana. Keep that in mind. Keep those effects in mind. Okay? However, the thing you need to remember is this. Most of the time, both of them should be present. What I mean by that is this, no? Is this. Our adrenal disorders, class, affects both mineralocorticoids and glucocorticoids. So, for example, in our hypersecretion, in our Cushing's disease or hyperadrenalism, there is an increase in cortisol. There is an increase in aldosterone. Okay? Now, because of that, the following symptoms are seen. Moon face and buffalo hump. Buffalo hump, no? This is weight gain in the face and neck. That the reason why there is moon face, there is weight gain, is because there is retention of water, which can cause edema. Okay? That is edema in your face. Buffalo hump, fatty hump between the shoulders, that is also type of edema. Fragile skin. Okay? Elevated BP, that is also because of the retention of sodium and water. Striae, when we say striae, class, these are stretch marks, no? These are stretch marks. High blood glucose is caused by your cortisol increasing your blood sugar. Hirsutism. Actually, class, hirsutism, another thing about Cushing is it will also increase androgens. Okay? So it will cause hirsutism or excessive hair growth, di ba? Excessive hair growth. Hair growth, no? And it will cause a decrease in potassium because if you remember, both of them will increase sodium and it will decrease potassium. Remember what you do have for potassium, you ECG, you monitor the patient's ECG. Now the treatment, taminaw na ko, revolves around the removal of adrenal. Lagyan mo yan ng malaking star class. Okay, sir. Sa tanan nga sir, all of them revolve around inhibiting. All of them revolve around inhibiting. Why is it? Entago mo wa asam to. Yala. Why is it that out of all of the kuan, why is it that now we are on the removal na? The reason why, class, is because there are two adrenal glands. Okay? This one and this one. There are two adrenal glands, no? So, for example, class, listen to me, ha? Listen to me. There are two adrenal glands. If one of your adrenal glands has a tumor here, then we can just remove one. And the other one will stay there. It will be the one to produce your hormones. Diba? That's your adrenals. So there are two. No? They sit on top of your kidneys. Class, if you don't know, they sit on top of your kidneys. No? So mo na siya. That's why we focus on our removal. That's the reason why, class, there's not a lot of cortical inhibiting drugs. More on replacement rata. Diba? Ano man, because replacement, class, no, that's for hypoadrenalism or Addison's disease. Addison's disease or hypoadrenalism is a hyposecretion, meaning so there will be a decrease in cortisol, there will be a decrease in aldosterone. Okay, aldosterone. Now, because there is a decrease in cortisol and aldosterone, remember, if there is a decrease in both of them, there will be a decrease in sodium and increase in potassium. So there will be decreased sodium. Okay? There will be elevated potassium. Because of that, you will feel fatigue. Diba? You will feel fatigue because potassium is a major electrolyte in the body. No? There will also be hypotension. And the reason why there is hypotension is there is a decrease in water, which will decrease your fluid volume and it will decrease your cardiac output. Balik na sa cardio ani. Bronze-colored skin is a pathognomonic sign of Addison's disease. Depression and low blood glucose is because of the decrease in cortisol. Now, class, listen to me. Why is there depression? Okay? Depression, class, is mostly due to a decrease in cortisol. A decrease in cortisol will also slow down CNS processes. Okay, it will also slow down CNS processes. Ayan, no? So the treatment around Addison's disease revolves around replacing adrenal hormones. Replacing adrenal hormones no atong pulihan. Okay? Now, listen to me. I will now discuss your synthetic glucocorticoids. Okay? Synthetic glucocorticoids and synthetic mineralocorticoids. But first, I will discuss their indications. Now, since glucocorticoids have a lot of functions, they are also used for a lot of things. Typically speaking, they are given orally, IM, IV, topical, aerosol, but no SQ, no subcutaneous. Okay? Synthetic glucocorticoids are used for replacement of glucocorticoids in hypoadrenalism. That is a given. Okay? This is given for autoimmune diseases. Nga naman. What are autoimmune diseases? Autoimmune diseases these are diseases that attack. Okay? Wait. Ito tulungan. Immune system. Immune system attacks own body. That's our autoimmune diseases like RA or multiple sclerosis or myasthenia gravis, no? Now, these drugs, mga good class, remember, synthetic glucocorticoids, they have the function of your glucocorticoids because they are basically the same, no? One of their functions, if you remember, if you look back here, no, is they will suppress the immune system. Okay? So, immune suppression. Okay? Now, you might say, oh, sir, bati man na. Sir, that's very bad. Because immune suppression can put you at risk for infection. However, in this instance class, in autoimmune diseases, we want the immune system to be suppressed so that the immune system will not attack our own body. It will stop the immune system from attacking our own body. Okay? Our synthetic glucocorticoids can also be used for allergic conditions like asthma, drug reactions, etc. because it has an anti-allergic effect. It can be used for organ transplant prophylaxis. Okay? Nga naman. Why? Let's say, for example, this is patient number 1. Okay, patient number 1. And this is patient number 2. Patient number 1 wants to donate a kidney to patient number 2. Kini siya na kidney class, it needs to be tested whether or not it can be accepted by patient number 2. We need to check for acceptance. Okay? Now, let's say, for example, class, ang iyang kidney, which is this one in blue, it has already been transferred here. Okay? Gibalin na to ato nagi-transport, ato nagi-transplant. We have already transplanted it. Now, there is a very high chance that that organ, that kidney, will be rejected by the body. Specifically, the body of number 2. Specifically due to immune response. Okay? So, what we need to do is we need to give a corticosteroid or a glucocorticoid because glucocorticoids cause immune suppression. They will stop the organ from being rejected and thus allow the organ to stay in the body more and more and more until it becomes acclimated and it will become accepted by the new host. It is also used, this drug can also be used for inflammatory conditions, osteoarthritis and bronchitis because this has an anti-inflammatory effect. And here's the thing sa inyong maternal class, lagyan mo yan ng malaking star class. Remember this class, lagyan mo yan ng malaking star. I'm putting checks on this. Pero kini siya star, no? In your maternal 2, you'll learn about this, no? Synthetic glucocorticoids will produce surfactants in newborns with immature lungs. Okay? Newborns with immature lungs, typically class, these are preterm newborns. You will learn more about this, no? Immature lungs. A patient who, a newborn who has immature lungs, they will be given, steroids, no? Synthetic glucocorticoids so that they will increase their surfactant production. A surfactant, mga good class, no? Helps lubricate and open up alveoli, no? So that's how this is used to mature the lungs of a newborn. So keep that in mind, nanas maternal to, no? Synthetic mineralocorticoids, these will involve, these are indicated for the replacement of mineralocorticoids in hypoadrenalism, diba? Because in hypoadrenalism there is a decrease in aldosterone. Okay, so mineralocorticoids, basically they replace aldosterone, no? Ngari class, no? In our glucocorticoid, there's a decrease in cortisol. Okay, so this can also be given for patients with hypotension and hyponatremia because remember, our aldosterone, no, our mineralocorticoid will increase sodium and water retention. Okay? So, this can be used typically, class, no? This is our synthetic corticosteroids. Now, I'm using the term corticosteroids, class, because both, some of them will be mixed. When we say mixed, we mean to say it has both mineralo, aldosterone, and cortisol, no? However, some might be isolated or individual, no? Isolated, no? So, the first two, our cortisone and hydrocortisone, these are often used, okay? These are short-acting. These are short-acting, and oftentimes they are used for hypoadrenalism. Okay, these are used for hypoadrenalism, or what we call Addison's disease. Diba? Addison's disease, hypoadrenalism, no? Typically, class, these two drugs also, no, they are also mixed. So they have both a mineralocorticoid plus glucocorticoid. That's why they are good for hypoadrenalism, because hypoadrenalism, class, is typically a decrease in aldosterone and a decrease in cortisol. So it's very good, no? Short acting lang na siya. Prednisone, methylprednisolone, prednisolone, and prednisone. Okay, kini silang tulo, methylprednisolone, prednisone, and prednisolone. Now, they are intermediate acting. Okay? Intermediate acting. Oftentimes, they are used for immunosuppression. Immunosuppression and as an anti-inflammatory. How or why? That's because, class, these are glucocorticoid only. Meaning to say, they do not have a mix of what we call the mineralocorticoid. So they are also only cortisol, synthetic cortisol only. Okay? Our beclometasone, betametasone, and dexametasone, they are long-acting. Okay, long-acting. No? They are used as potent anti-inflammatories. They are also used to mature lungs, no? To mature lungs of preterm newborns. And no. They are also kwan po din sila, class, they are also glucocorticoid only. Glucocorticoid only. Ayan, glucocorticoid only. Okay? And then lastly, we have our flucortisone and fludrocortisone. These are mineralocorticoids only. So they do not have the effect of the glucocorticoid. They are isolated. Okay? So what do we need to remember when it comes to these drugs? You need to obtain baseline weight and urine output. Remember, these drugs will also affect, okay, our sodium, potassium, and water secretion and excretion. So that's why we need to monitor the patient's weight, especially because, no, some of these drugs can cause what we call edema, no? Because this will retain, di ba? These drugs, no? Remember, these drugs will increase your aldosterone, no? So it will increase water retention, which will cause increase in weight and urine output, no? Monitor vital signs because corticoids can increase BP due to sodium and water retention, record weight, report if the weight gain is greater than 5 pounds in 1 to 2 days. Report na nimo siya, class. That's too much, no? Monitor laboratory values, especially sodium, potassium, and blood glucose levels. Muna silang 3 the most affected lab values, no? So when you are giving these drugs, typically sodium will be increased, potassium will be decreased, and blood glucose will be increased, no? Watch out for hypokalemia, which will include nausea, vomiting, and muscle weakness as its signs and symptoms, no? Remember, class, for hypokalemia, class, no, you need to monitor patients ECG, diba? Monitor patients ECG, no? We already know what to do with hypokalemia. Monitor patient ECG, give them potassium-rich foods, diba? If discontinuing, taper to prevent adrenal crisis, no? Taper to prevent adrenal crisis. This is key, class. Lagyan mo yan ng malaking star, okay? Slowly put it down. Like for example, class, in day 1, let's say for example, in day 1, you are giving 4 tablets, no? In day 2, class, you will now reduce it, class, no, to 3 tablets. Okay? In day 3, you will now reduce it to 2 tablets. Ano ba? In day 4, you might reduce it to something like 1.5 tablets, di ba? And in day 5, you might give 1 tab. And at day 6, no, you might give 0.5 tab. And at day 7, di na ka mo give, di ba? Day 7, none, no? So that's how you taper it. This is to prevent adrenal crisis. Okay? Instruct the patient to avoid persons with respiratory infection and other infectious diseases. Lagyan mo to ng malaking star. Because if you increase, listen ha, if you increase your glucocorticoids, it will cause immune suppression. Okay? So, remember that immune suppression is an increased risk for infection. Ayan. So, these drugs suppress the immune system na amday, no? So, that's it. Okay? That's it. That is basically the basics of these drugs, no? Next meeting, I will discuss anti-diabetic drugs. It's quite long. Kanto siya may taas. No, this is short. Actually, I'm telling you, this is quite short, no? So, mga to siya, no? Goodbye. Keep safe. I know there's a typhoon coming, so hopefully, class, no, dili ma-overextend ang atong Y klase, ang atong koan on